You are watching McLaren Port Huron Today's Health Program, and we're talking about extended breast services that are available at McLaren Port Huron. And I'm speaking with one of our experienced breast surgeons, Dr. Kimberley Clark-Paul. So Dr. Clark-Paul, I know your experience as a general surgeon is quite extensive. Can you tell us a little bit more about yourself?
Well, so initially after I finished my training in general surgery, I did a fellowship, which was additional training in cancer surgery. And it was broad spectrum cancer surgery at University of Miami, and after which I stayed on as an associate professor of surgery. However, my focus and interest has always been in breast cancer. So while I was there, I helped develop a breast program, and I did a lot of work in breast cancer. But then when we moved back to Michigan, to Port Huron, it was necessary to do general surgery. And so for many years I did general surgery, and then recently I've been able to focus exclusively on breast surgery.
Oh, that's great. So what types of breast conditions are you treating?
So we treat everything from benign breast conditions, lumps in the breast, infections in the breast. Maybe it's a rash in the breast and the patient's concerned about what's the cause of the rash. So maybe it's just fibrocystic breast changes and breast pain. So we treat everything from the benign breast changes to breast cancer, to early breast cancer, and to more advanced breast cancers. And obviously, my greater area of interest is on the breast cancers.
Okay, so everything from benign being non-cancerous.
Correct.
That's great.
Correct.
So how is breast cancer usually diagnosed?
Well, the way that it's diagnosed, sometimes it will be diagnosed because the patient feels something in their breast, or they see some skin changes in their breast. But most of the time, today, it's diagnosed because there's a radiographic change in the breast.
Okay, so I know some of the guidelines have changed about if women should be doing breast self-exam, but if you're saying patients are seeing some of these changes themselves, really they should be familiar, right?
Correct.
In those screenings. And the radiographic, you're talking mammogram, so the screening
Correct.
Mammograms.
Correct.
That's great. So if the patient does come in to have the mammogram and you find something, how is the breast cancer diagnosed?
Well, in order to actually make a diagnosis, you have to have tissue. And so the easiest way is that we can do what's called a core biopsy. Sometimes we'll do a fine needle aspiration biopsy, and that just gives us cells, but most of the time we'll do what's called a core biopsy. And what happens is, if something is seen radiographically, but you can't feel it, then we will use either ultrasound-guided core biopsy or what's called a stereotactic core biopsy. In the ultrasound core biopsy, via ultrasound, a needle's directed precisely to the area of concern, and a core of tissue is obtained, and the patient doesn't have to go to sleep. They have local anesthesia, but they can drive home. Sometimes they want to take something for anxiety, but if not, then they can drive themselves. And the stereotactic core biopsy is if we can't see it on ultrasound, but we see something abnormal on mammogram, usually it's microcalcifications, then the patient lays on a table with their breast through an opening in the table. We exactly direct a needle to that area of concern after the breast has been numbed up, and we take a sample of tissue from that area. Once the area is identified, the actual biopsy itself takes less than 5 to 10 minutes. And then what we do after the biopsy is we leave a little marker behind. It's a radio-opaque marker, because if that should be something of concern and we would need to go in surgically, that will identify where the location was.
Okay. That's great. So if that result does come back as it's positive for breast cancer, what surgical options are available for women?
Well, I'm glad you asked that question. So surgical options, first of all, it depends on the stage of the breast cancer as to what we're going to do. But if it's an early stage tumor and surgery is the thing that we're looking at, what women need to understand is that whereas years ago people would get mastectomies, really probably the minority of people are getting mastectomies for early stage breast cancer today. And what my additional interest in training is something called oncoplastic surgery. It's using plastic surgical techniques to remove the tumor so that the patient has the least deformity possible with the treatment of the tumor. So treatment options include, first thing that we do is we like to identify whether there's any spread to the lymph nodes under the arm. So that's called a sentinel node biopsy. And then the second thing that we focus on is the treatment of the breast itself. And that can either be done by removing the breast, plus or minus reconstruction, again, which is not usually the norm for small tumors now, or a lumpectomy in which we remove the tumor, but we try to do it the most cosmetically acceptable way.
Gotcha. Okay. So you talked about the sentinel node biopsy. I think a lot of people hear about that and wonder, what it is. Can you explain what?
So the sentinel node biopsy is, there is a thought that tumor will travel systematically from the original site to the first lymph node basin, which could be the lymph nodes under the arm. Now there's some theory that when tumor starts it's systemic already, but we know that if there is tumor under the arm in the lymph nodes under the arm, that's got prognostic significance. So what we do is we have the patient injected with a radioactive substance around the nipple areolar area. We then use it's a Geiger counter in the operating room that identifies the lymph node to which that would travel. We can make a small incision, take that node out. That's called the sentinel node or guard node, and then I'll send it for a frozen section evaluation. If on frozen section there's no macroscopic disease, then we don't have to take the rest of the lymph nodes out, which decreases the risk for lymphedema or swelling in the arm.
Right. Very good. And you talked a little bit about some of the surgical procedures, lumpectomy and mastectomy. Can you tell us a little bit more about what options are available for reconstruction too?
And I'm very glad that you asked that question, because again, oncoplastic surgery is the way that I am now doing my lumpectomies. So what happens is, it's my objective to make my incision in the place that will be least conspicuous, and then after I remove the tumor, what I do is, first objective is to make sure that we get all the tumor. So we remove the tumor, and after I remove the tumor, I send that specimen down for an X-ray to see that the tumor itself is located in the center of my specimen. And then I'll use a device called a margin probe, which sometimes it helps, sometimes it doesn't. But what it does is it gives us an indication whether there may be tumor at the margins. I do it intraoperatively, and if I need to, I'll take wider margins. And then the other thing that we do is just by palpation and seeing how it feels, how the specimen feels. And then we send that off to the pathologist. We mark it, we paint it in the operating room to orient the specimen so that the pathologist will know where's our superior margin, where's our mediolateral, and then we look at all of those margins. They'll look under the microscope very closely. So once I'm satisfied that I've done my lumpectomy and taken as much tumor as I need to, the next thing that I'll do is it's the oncoplastic portion of the procedure, where I can rearrange the tissue to fill in that defect that I've created, and I often will use a device called a biosorb, which is a spiral device that helps fill the cavity in and has actually titanium clips in it so that it marks my cavity site where the tumor was, and it allows the radiation oncologist to know where to deliver their targeted therapy to that area. Often the whole breast gets radiated, but we'll get a boost to that tumor site. So I do the tissue rearrangement that is necessary, and then use a plastic surgical closure to close the incision. So that's the lumpectomy. If I can, then that's my choice. If I can't do an oncoplastic procedure in that fashion, and I have to do a mastectomy, I work in conjunction with the plastic surgeons, and I'll often do what's called a skin-sparing or nipple-sparing mastectomy to leave as much of the breast tissue envelope as I can for the mound to be created. And we have some really nice results cosmetically with that. As a matter of fact, I've had patients say, I thought you were going to do breast surgery. I say, I did. And they'll say, but where's the incision? So nothing makes me happier than to have that kind of an outcome.
Yeah. That's great. And I know if anyone that's concerned about breast cancer, but really they might be fearful, to learn more about it, but really the best defense is to come in and get screened early.
Absolutely.
So we can do more of those tissue sparing things like the lumpectomy.
Absolutely.
So,
absolutely.
Thank you so much for sharing this information. This is very valuable for our audience. I appreciate you coming today.
Thank you.
And we do need to take a break, but we will continue our discussion about breast services here at McLaren Port Huron when we return.
Hello, I'm Jennifer Montgomery, President and CEO at McLaren Port Huron, and I'm excited to invite you to come visit our brand new patient tower. Construction is complete and we are open to have you come visit us. We will be open for business on October 15th, but prior to that, please come see us on September 29th between 10 and 2 p.m. We have a variety of activities planned for you and your family, and there will be complimentary refreshments available. We will have valet parking out front and shuttle service available from nearby parking lots. I hope you and your family are able to join us for the celebration and grand opening of our new patient tower.